The second paper that I'm going to discuss this afternoon was an important study that was led by the Mito Mango Italian cooperative groups in gynecological cancer as part of the ENGOT collaboration. And that was addressing a very important question, and that is re-challenging patients with bevacizumab. So in this randomized trial, patients who had all received bevacizumab in the frontline setting were randomized at recurrence, at a platinum-sensitive recurrence, to either standard second-line chemotherapy or that chemotherapy plus the addition of bevacizumab. And what the data showed was that by reintroducing bevacizumab into these patients, you increase the response rate, which we know is important in patients with recurrent ovarian cancer, and indeed the progression-free survival. So it did not appear that resistance to the effect of bevacizumab had developed merely by using that drug in the first-line setting. Interestingly, there were a proportion of patients who, although they had a more than 6-month interval between the last platinum and relapse, were still on bevacizumab at the time that the disease progressed. These patients were also treated in the trial, and the subgroup analysis on the forest plot didn't show that there was any less effect in these patients either. So to me, the interpretation of these data is that patients generally don't, or tumors don't become resistant to bevacizumab. There are other factors that cause the tumor to grow through, but if you reintroduce the bevacizumab, either with chemotherapy and then as maintenance, you can again extend the benefit in terms of progression-free survival. Now, the implications of this are quite important. Partly in the USA, bevacizumab, after 7 years, has now been licensed in the first-line setting, so more patients in the USA will be receiving the drug first-line, and the question is, well, can we use it again? In continental Europe, it's licensed in both first-line and in second-line settings, so I think that gives confidence to clinicians to use the drug again. In the UK, we're in the unfortunate position of not having access to bevacizumab either in the platinum-sensitive recurrent setting or indeed in the platinum-resistant setting. And I think there is an interesting question that people will want to ask themselves is, because the Pinata trial has shown bevacizumab after bevacizumab in the platinum-sensitive setting is beneficial, can we infer that we can use the drug in the platinum-resistant setting again, having used it in the first-line setting? When the original data came out on the Aurelia trial for platinum-resistant disease, it was in patients who had not previously received bevacizumab. So people will be asking that question. I don't think anyone's going to be doing a trial of Bev after Bev in that setting, but I think people will make that logical step and say, well, if it works in the platinum-sensitive setting on re-challenge, why not use it in the platinum-recurrent setting? Whether or not the company will be able to get an extension of their label or change in the label to accommodate that, I don't know. But I think in terms of clinicians out there who have the ability to use bevacizumab at different phases of the treatment will probably make that step, and I think that would be entirely reasonable.